Okay, everybody. It looks like Zoom is still filtering people into the room. As I said, we've got quite a few attendees here tonight, but I'm going to go ahead and get started. I think people have been to a lot of webinars these days, so we want to keep ourselves relatively well on time. So welcome to Psychedelics Psychopharmacology. This is a webinar hosted by Fluence, featuring Kelan Thomas, and I'll tell you a little bit about Kelan in just a moment. First, I want to introduce myself and introduce our program, Fluence, tell you a little bit about why we're here and who we are, and welcome you, and a little bit about how tonight's webinar will operate. So by way of orientation, many of you have been to some of our programs before, but Fluence is an independent continuing education program that is dedicated to providing education for professionals in healthcare and mental health care and related fields in the field of psychedelic-assisted therapy and psychedelic integration therapy. So we have our focus squarely in the developing, emerging psychedelic-assisted therapy world. Fluence was founded by myself, Elizabeth Nielsen, and Ingmar Gorman, who is here with us tonight as well. We're both psychologists. We both work on clinical research projects of psychedelic-assisted therapy. And we're bringing you this program in order for you to have a point of access and a way to access professional education in this field. We founded Fluence over a year ago now, and we've really been growing quite nicely, really welcoming a lot more people into the field and into our educational programs. And this is really a wonderful starting place for a lot of people. We try to do a lot to build community and help people get oriented to the field, as well as connected to other kinds of resources and connected with each other as a resource for beginning to be able to incorporate this this kind of knowledge and this kind of work into your practice as healthcare providers or therapists or whatever field you may be in. So I really encourage you to check out more of our programs. If you're not familiar with them, I'll post some links for you. But tonight's program is a webinar on psychedelic psychopharmacology. And Kelan Thomas is joining us from, Kelan, you're calling in from Oakland, California, is that correct?
That's right.
That's great. So I want to just take a minute to introduce Kelan, because he's joining our Fluence team very recently. We've known him for quite a few years now. We've known him through the professional networks and through the conferences. Kelan is a pharmacist and associate professor and psychiatric pharmacist at Touro University of California. He is an associate professor and board-certified psychiatric pharmacist with outpatient behavioral health practice sites in San Francisco and Oakland. His research interests includes adverse reactions and drug interactions related to psychiatric medications and psychedelic-assisted therapy. He's had the distinction of working on some of the very current research projects in the psychedelic-assisted therapy world, and publishing on some topics that I think are really important for anybody who's working in this field to be familiar with. And one thing that I really always appreciate about his work is that some of these topics can be a little bit confusing for those of us who might not have a medical or more of a pharmacology background, but he makes these topics very accessible and digestible and relative and relatable to the kind of work that those of us with a more psychotherapy background will be doing. So I will tell you a little bit more about some of our programs at the end. I encourage you guys to use the chat and say hi. We've got several hundred people on the line and more following the live stream on YouTube. We also have the Q&A available for you. If you have a question during the event that you'd like us to bring up in the Q&A session at the end of this, I will be doing a moderated Q&A. So if you post it in the actual Q&A at the bottom of your screen, it'll make it easier for me to find it. Sometimes people post questions in the chat and they're great, but they get lost. And sometimes they also get addressed right there in the chat. So you've got those two options. We'll be monitoring the chat and chiming in as needed. And then at the end, I'm going to tell you about a few more opportunities to get involved and to get more education in this field through Fluence, some more of our upcoming events, and even a class that Kelan is going to teach that will give a much longer format about some of the topics introduced this evening. All right. So without further delay, I'm handing it over to you.
Great. Thank you so much for inviting me, Elizabeth and Ingmar, to give this presentation today. So we'll get started here. Okay, so today I wanted to provide a brief overview of some of the pharmacology related to psychedelics and have a little bit of time there at the end, maybe 10-15 minutes for some question and answer discussion. But to talk about first psychedelics and psychopharmacology background information, then going into a little bit about pharmacodynamics and the efficacy mechanism of action, or why we think maybe some biological reasons these medications are helping treat psychiatric disorders, and then pharmacokinetics and some of the safety and adverse effects and drug interaction elements related to psychedelics. So first I wanted to give a bit of background that really we owe a large debt to the whole field of molecular psychiatry from psychedelics. So Albert Hofmann's birthday would have been this past week, and in 1938 he synthesized it, and then 43 recognized the effects of the molecule LSD-25, and then this was distributed in the 50s, and psychiatrist Dr. Osman, along with correspondents of Aldous Huxley, coined the term psychedelic or mind manifesting. And very shortly after this, serotonin was first isolated in the brain. LSD effects were attributed to the serotonin system a year later. And then we started to see development of serotonergic antidepressants, starting with the oldest class of tricyclic antidepressant, imipramine. So a lot of modern molecular psychiatry was in part catalyzed by the discovery of LSD. And this Nichols paper is a great review of all the complex pharmacology related to that. So I kind of think of psychedelics into these 5 very broad categories. We're going to focus today on just these 2 of tryptamines and phenethylamines. And then other things like ketamine are listed as aryl cyclohexamine, and then tropanes would be plants like datura or nightshade family. But we're going to focus today on psilocybin and DMT as it's contained in ayahuasca, and then also the phenethylamine MDMA. So pharmacokinetics, when I say that term, I mean in terms of what does the body do to the drug. So I'm thinking about absorbing of the drug once you take it, how it gets distributed throughout the body, how the body starts to break it down and eliminate the drug. So pharmacokinetics is the study of all these variables of what's happening with the drug in the body. The other aspect of pharmacology broadly is pharmacodynamics. And this can be thought of more what the drug does to the body. So these are the so-called psychedelic effects that people know. That would be a pharmacodynamic effect, all the different sensory changes and things that you experience. So when we think about pharmacology, we're thinking about how does it get into the body, what's happening with the molecules being broken down, and then where is the drug going within the body to cause various biologic responses, which some of those could be for efficacy or benefit, the beneficial effects, but some of them could be more toxicity or adverse related effects of the medication. So we'll start with the 2 tryptamines, psilocybin and DMT. So these would be considered in the class called tryptamines, and these have a strong chemical similarity to the neurotransmitter in the brain, serotonin. So you can see the molecular structure of serotonin as the 5-hydroxy position, while psilocin is at the 4-hydroxy position. And the reason I talk more about psilocin than psilocybin, we'll see in a moment, is the body very rapidly converts psilocybin into psilocin. And then DMT over here on the left-hand side has these just 2 extra methyl groups. That's where the name dimethyl comes from tryptamine. And our body can synthesize serotonin from things like tryptophan, the amino acid. So psilocybin and psilocin, which I'll be talking more about since the body so rapidly converts to psilocin, is found in magic mushrooms and various species of fungus. The most prominent are things like psilocybe cubensis, cyanesins, mexicana, but there's many, many varieties. And usually there's 3 main components we think are psychoactive to some extent, possibly is the psilocybin, the psilocin, and the baeocystin have various percent concentrations within, depending on what type of mushrooms you have. And the dosage can be quite variable in the mushrooms. So it's hard to predict exactly how many milligrams of each one there's going to be without doing some sort of analytical chemistry testing. And psilocybin, like I said, is considered what we call a prodrug, where the body can rapidly convert it into the main drug, which is psilocin, and that's about double the potency of psilocybin. The dose range when you see psilocybin is about 10 to 40 milligrams. In most of the clinical trials, they've been sticking to around 20 to 30 milligrams for most of the clinical trials that have been done so far. And the duration of effects are roughly 4 to 6 hours. And the half-life is pretty short compared to most drugs that we think of in psychiatry. It's only 3 hours. So why that half-life is useful, what that tells us is how long it takes to break down in the body. And so when there's 5 half-lives are complete, we sort of assume that the drug is almost completely eliminated. So 5 times 3 would be 15 hours. So within less than a day, you're almost getting to undetectable levels of psilocybin in the bloodstream. Ayahuasca is a little bit different. So ayahuasca is this combination of the dimethyltryptamine and these compounds called monoamine oxidase inhibitors. So within ayahuasca or yahe, there's 2 different plants, the Psychotria viridis or the Diploteris cabrerana. And these are the plants that contain the DMT component. And then they get mixed with a vine called Banisteriopsis caapi that has these harmala alkaloids called harmaline, harmine are the 2 main ones that are reversible monoamine oxidase inhibitors. And we'll look at that in the synapse here in a minute. And the dosages are pretty variable amongst the different brews, but the MAOIs are critical to allowing for oral absorption of the DMT from the plant. Normally DMT is broken down so quickly that you wouldn't really absorb any if you just took the plant by itself without the vine that has the monoamine oxidase inhibitors in it. So the dosage range there is between roughly 20 to 40 milligrams of DMT in a cup of the brew. And in the clinical trial that was done by Paujano Fontes, they did a 25 milligram dose in their clinical trial for depression. And then harmine and harmaline can have quite variable ranges in terms of the milligrams are listed there. And the duration, again, is around this 4 to 6 hour window. The half-life of DMT is very short, and it gets a little bit longer if we prevent the breakdown with these compounds like harmine and harmaline. Classic psychedelic effects, people are probably familiar with these, things like synesthesia, delusions or false beliefs or illusions, seeing things that are shifting the way you're perceiving it, and occasionally hallucinations, although they're more rare than we used to think than they were called hallucinogens, but they don't often cause frank hallucinations. It's more of distortions in the visual environment. And things that affect that a lot of my colleagues, including Elizabeth and Ingmar, have written about is the set and the setting and how that can influence the effect of these molecules. So a first-time user might get more anxious or disoriented, while experienced users may notice more euphoric sensations. So a lot depends on the setting you're taking the molecule in and your mindset coming into the experience. And then we also think about things like pre-existing mental illness. There's some concern that people with more instability through disorders like bipolar, schizophrenia, may result in unmasking some symptoms like mania or psychosis with these molecules. The classic psychedelic effect adverse effects that we think of when I did an overview of a lot of the trials that have been done, which will be published in a textbook called Handbook of Medical Hallucinogens, released next month. Things like anxiety, disorganized thoughts, these illusions, and feeling some fatigue are common adverse effects that people experience. And then on the physiologic or physical side, things like high blood pressure or high rapid heart rate. Tachycardia is rapid heart rate. Hypertension is high blood pressure. And things there, it's about a 15 beats per minute change in heart rate and a 20/10 millimeter mercury blood pressure, whereas normal blood pressures are about 120/80 millimeters of mercury. Headaches in about a quarter to half of people, nausea in about 15 to 30%, and then ayahuasca seems to have even higher rates of nausea and vomiting, maybe up to 50, 70% in some of the clinical trials. Synaptic neurotransmission, now we're going to zoom in into where in the brain this is all taking place. So over here is the serotonin neuron. And so it's releasing the serotonin neurotransmitter and then binding to this postsynaptic serotonin receptor. We're going to talk a lot about specifically the serotonin 2A receptor, which is where we think is involved with the psychedelic effects. And then the serotonin and the drugs that we're talking about can also be broken down by monoamine oxidase enzymes. So let's zoom in to the synapse here. You can see the psilocybin bound to the serotonin 2A receptor here. And then it leads to a series of downstream or second messenger systems, such as GQ protein, the phospholipase C or A2 pathways, beta-arrestin pathways. There's still a lot of work to be done to really well characterize exactly what's going on downstream from the initial activity at the serotonin 2A receptor. And so psilocybin and DMT are partial agonists binding specifically at that postsynaptic receptor to cause their effects. When this is normally functioning, serotonin is just being released and taken up as signaling is happening. So you can almost think of this serotonin neurotransmission as dialing up the gain on and making the likelihood of a cell firing more or less. So it's not a simple on-off switch. It gets a little bit more complex, and we'll talk about that. So when we zoom in even further, this is what the receptor actually looks like in terms of the transmembrane domain. So G protein coupled receptors have all these different pockets and ways that the molecule, so the agonist here in this picture would be the DMT or psilocybin, can come into this three-dimensional pocket, and the way specifically it gets bound in there can lead to all these different downstream effects, or something called functional selectivity or biased agonism. So when the agonist binds it to the receptor, it uses these G protein signals to cause different effects throughout the body. So when I say the term partial agonist or full agonist, that means that that signal that's occurring at the receptor with a full agonist, something like serotonin, the natural or endogenous neurotransmitter in the brain, is considered to have a full effect. So that would be 100% of the response, while these psilocybin and DMT are more partial agonists where they're having some level of response, but maybe not the full effect. And it's more the downstream signaling that's causing these differences in effect. So when I think of pharmacology and drug binding to the receptor, I think of the affinity, which is almost the stickiness or tightness, how well it's going to fit into that pocket, and then what response it causes, how much of an effect do we see at the receptor. And so that would be, our psychedelics would be in this partial agonist area here. So people have done some studies. This Rickley paper has a lot of data on various tryptamines and their effects specifically at the serotonin 2A postsynaptic receptor here. So again, they have that Ki value. So the lower the number this is, the stronger the affinity is for the receptor. And so 49 nanomolar is pretty good. That would be something that people would develop drugs for, to target that receptor. Usually when drug development, something lower than about 1 micromolar or would be relevant for binding. So the lower the binding affinity value, or that Ki value, the stronger it is at the receptor. And then the higher activation is these efficacy values. So activation, efficacy, percent maximum, leading to some response biologically. So in this case, they looked at calcium influx, which is one of those second messenger responses. And you can see it's only about 16 or 40% of what the serotonin would be. So it tells you that it's more complex and there's a lot to be learned at these second messenger systems. So how does this pharmacodynamics work in the brain? So there's this interrelationship between the amount of drug that gets into the body and where it goes within the body, and then the intensity of those drug effects. So this was a really elegant paper done in Denmark by Martin Madsen at University of Copenhagen, where they started to look at plasma psilocin concentration. So this is what can be measured in the bloodstream after you take the psilocybin pill, and seeing how much of a level there is. So you can see that there's a general response. The higher the dose a person got, the more of a concentration there was in the blood. And that fairly well correlated with how the receptors were occupied, and also the intensity of the psychedelic effects, which are what's being rated on the B section here. So when they were looking at what's the effective dose range, probably somewhere between 15 milligrams and 30 milligrams, basically everyone had a very full intensity of those effects. And so we're still learning about what might dictate who responds more or less, because there is still some variability in terms of the level, not always matching exactly to the amount of drug, because each person has a different biological matrix, essentially, in which the drug gets metabolized. So that tells us a little bit about the pharmacology and what's going on. So now I want to talk about the interesting markers of efficacy with neuroimaging that's been done. So the default mode network, if people haven't heard of that, that's essentially your resting consciousness. You're just sitting there doing nothing, things are happening in the background. And the more connected that is, the stronger there's a sense of self. And the major region that we see come up again and again in clinical trials is this posterior cingulate cortex with the orangish and the green dot there. And the connections between that and the medial prefrontal cortex, the front of the brain that does a lot of executive functioning and emotional regulation, and the subgenual cingulate cortex, a lot of these studies are looking at those connections. So the Carhart-Harris group at Imperial College of London developed this entropic brain hypothesis that talks about the more connected that default mode network is, we might see certain things like depression, OCD, or addiction to the right side, where there's rigid states and hyperconnectivity in that region. And when there's less connectivity or more entropy, there's more flexibility in the signaling in the brain, and that would mimic more of what's happening in our psychedelic state. And why I think the neuroimaging is so compelling is that even in depression, when people aren't taking any medication, these regions of the brain are highly correlated. So there seems to be more default node network or connections between regions of the brain with the posterior cingulate cortex and the subgenual cingulate cortex that can predict people's subjective ratings of the rumination, or thinking the same thoughts over and over. They just can't get out of thinking the same thoughts. And that's a pattern we see very consistently in things like depression and addiction. And so when they looked at just people who were not taking any psychedelics, not taking any medications, they could predict whose symptoms would probably be rated higher in rumination and anxiety and depression and severity by looking at this connectivity in the posterior cingulate cortex. So that's in the sort of health in a depression population. Now we're going to look at what happens when you add the drug and then do an fMRI type of neuroimaging scan. So in this case, this is the placebo condition. You can see there's plenty of activity still in the red between the posterior cingulate cortex and subgenual cingulate cortex and the medial prefrontal cortex. And that all quiets down after the introduction of psilocybin. So this blue indicates a decrease in connectivity between that posterior cingulate cortex and the medial prefrontal cortex. They also showed at the Carhart-Harris lab that there's this desynchronization. So we have this relationship between the connection across the brain, but also there's a rhythmic firing within the neurons in our brain. And so this alpha power desynchronization led to disintegration of ego. So again, predicting the experience from the way that the synchronization of that region of the brain was happening. And that's what they showed was there's different connections happening with different regions of the brain instead of the more typical default mode network connections. This is the same thing seen not only in psilocybin, but also in ayahuasca fMRI brain imaging studies by Palhano Fontes lab down in Brazil. So they also found ayahuasca decreased within network functional connectivity in the default mode network, largely driven by that posterior cingulate. And they said that nearly identical alterations in functional connectivity that were seen in the psilocybin studies. So that does tryptamines. Now we'll move on to phenethylamine compounds, or MDMA is what we're going to talk about today, specifically in that category. And these are more related to catecholamine compounds, things like dopamine, norepinephrine neurotransmitter, and epinephrine. And so you can see the chemical structure there and how it relates to MDMA's molecular structure. So these phenethylamines, as I said, are related to dopamine, norepinephrine, and epinephrine. And the reason this is more of a concern is norepinephrine is the main neurotransmitter that acts on our heart tissue. So there's beta receptors in the heart and alpha receptors in the blood vessel that can change how rapidly our heart is beating or change the sort of blood pressure and heart rate effects. And so there's more concern with these types of compounds of more cardiac related effects. So the Entactogen MDMA, a little bit different. People often refer to it as an entactogen or touching within, this 3,4-methylene dioxymethamphetamine compound that is purported to be in ecstasy, although we never really know unless you've gotten that tested what's in ecstasy. There's been a lot of additives and things over the years. And some of that gets converted to an even older drug that Shulgin was involved in synthesizing, MDA. And the dosage range for this tends to be somewhere between 75 to 125 as a single dose that have been looked at in the clinical trials. And now MAPS for phase 3 has settled on the 80 milligram dose. Duration here is about 3 to 6 hours. And it does have a longer half-life than the tryptamines we just talked about, so more like 8 hours. So in 5 half-lives, it's going to take about 2 days for the drug to be completely eliminated from the bloodstream. Entactogen effects, so people may be familiar with these, things like empathy, euphoria, openness, or tactile enhancements. Also still affected by the set and setting, much like our tryptamine psychedelics. And experience with the drug can certainly change the effects, much less likely to cause anxiety and confusion than the classic psychedelics like LSD or psilocybin or DMT. And that has to do a lot with their pharmacology. And there's still maybe some concerns about mania or psychosis symptoms, although probably less of the psychosis because that's not usually the way that the MDMA triggers effects in the brain. We see less of those illusions or hallucinations, things like that occurring with MDMA compared to the classics. Adverse effects, here we see more of the restlessness or inattention as the effects that people have complained of in clinical trials. And then physiologic effects, or the physical problems, are the increased heart rate and increased blood pressure once again. And as you can see, most of them are just a little bit higher than we saw with the tryptamines, more like 20 beat per minute on average changes, or 25/15 with blood pressure. We do see more dry mouth and jaw tightness, up to 50 to 75% in trials with this medication, and that is related to its amphetamine-like effects. Some dizziness and imbalance as well, and then sweating are some of the more common effects that people complain of. So where is MDMA acting when we go back to our synapse picture here? So MDMA is more affecting on the presynaptic side, or the side before the release. So it gets taken up through these serotonin transporter pumps that, once the serotonin is released, recycle it. And so it gets into that serotonin transporter and disrupts something called the vesicular monoamine transporter that helps repackage and keep these serotonin in these vesicles for release. So essentially it stops that process, and then some of the serotonin starts to flood back into the synapse. So it's even a greater effect than something like an SSRI, for example, which would only block the reuptake. With the MDMA, it's blocking the reuptake, but it's also causing spillage of serotonin back out through these transporters. And when we look at, this is a very recently published MDMA fMRI brain imaging study that found that decreased within network functional connectivity for the default mode network once again. So we're seeing this consistent pattern, and there may be overlaps between how MDMA or psilocybin or DMT could be used for various psychiatric conditions. I know in the UK, they're starting to investigate MDMA for alcohol use disorder, and psilocybin at NYU has one of the largest clinical trials. So there could be some overlaps, and it could be related to these changes in neuroplasticity, where we get a lot of benefits then from the psychotherapy added to this window of changing in the brain thought pattern and connectivity. So for the last section of the talk, I'm going to turn our attention to more of what the body does to the drug. And this is what I often think more about when I'm thinking about drug interactions and adverse effects. So I want to look at pharmacokinetics data, looking at concentrations of how much concentration is in the blood, what's the maximum concentration in the blood, how much exposure overall is the person getting during the window. So all this green shaded area is what we call the area under the curve. And this is a proxy for how much total drug exposure the person gets, as opposed to Cmax being more like the peak effect of the drug. And then that half-life, what I was talking about, is the time that it takes for half of the drug to be eliminated by your body. And after about 5 of those half-lives, we expect the drug to be pretty much undetectable and not having any effect in the plasma, in the bloodstream. So how do these drugs get out of our body once they're in the body? They get out of the body through a complex sequence of various enzyme interactions that can essentially do chemical changes to the molecule. And so the first and most rapid step, to where it's very difficult to even detect psilocybin in the bloodstream after giving it, because after it's absorbed from the gut, it very rapidly dephosphorylates from the alkaline phosphatase enzymes. And then that leads to the psilocin, which goes throughout the body and into the brain to cause its drug effects that we saw at the receptors. And then psilocin gets broken down by monoamine oxidase, particularly the A form of it. And then it also gets the main pathway actually of elimination and metabolism for psilocin is through something called glucuronidation. And so that's doing through UGT1A9 enzyme and UGT1A10 enzymes. So most of the drug gets eliminated as psilocin glucuronides. DMT, on the other hand, as I mentioned, is very rapidly broken down by monoamine oxidase, to the point where if you just took an ayahuasca plant by itself, you wouldn't really notice any effects from it. Whereas when we add those monoamine oxidase through the harmala alkaloids, that's where we prevent the breakdown of the DMT pictured here, NN-DMT. And some of that is also broken down by enzymes in our liver called the cytochrome P450 enzymes. These, if people have looked at drug interactions, this is what we most frequently look at for clinically relevant drug interactions. So in this case, CYP1A2, CYP2C19 are some of the enzymes that break down the DMT, but a lot of it is coming from the monoamine oxidase. And then because we're talking a little bit about ayahuasca, we have to consider that there's 2 drugs in ayahuasca, not just one. And so these MAOI pharmacologic effects through the harmala beta-carbolines become important because they prevent the breakdown, as I said, and they themselves can also have effects on the liver enzymes too. So harmaline and harmine are inhibitors of the liver enzyme CYP2D6, and so could affect the way other drugs in the body are broken down, as well as preventing the breakdown of DMT. And CYP2D6 is a major enzyme we think of clinically for drug-drug interactions. So that talks about the tryptamines that we discussed. Let's move to MDMA, the phenethylamines. This is predominantly broken down in metabolism by the cytochrome P450 enzyme. So you can see a lot of them listed here. CYP2D6 seems to be one of the major elimination pathways. And interestingly, MDMA is an autoinhibitor. So what that means is not only is it broken down by CYP2D6, but it can also prevent its own metabolism after a couple hours. So it actually prevents and inhibits its own metabolism. And so after the first couple hours, you essentially are blocking the breakdown through CYP2D6, and some of these other enzymes become more prominent, CYP1A2, 2B6, 2C19, and 3A4. So there's still a lot of work. The Liechti lab is in Basel, Switzerland, is doing a lot of work on looking at the breakdown of MDMA. So the reason this becomes relevant is because at the end of the day, clinically, I'm worried about these drug-drug interactions. So there's quite a few different ways that there can be drug interactions occurring. So I've highlighted some of the psychiatric medications in red that people could be taking before or after they try psychedelics for various psychiatric disorders. And then I want to draw your attention here to the fact that harmaline, harmine, and MDMA are also inhibitors of these enzymes. And so they might prevent the breakdown of other psychiatric medications or other medications people are taking. And then on the inducer side, that means it's speeding up the breakdown. So an inducer means it's speeding up the metabolism. And so things like St. John's wort, which people use for depression, may speed up the metabolism of something like MDMA. So the last 2 slides here, I just want to talk a little bit about the drug interactions that we know about from the clinical evidence and trial literature. So these are not trials for a psychiatric disorder. These are just healthy volunteer looking at things like subjective effects or blood pressure. And so what we know is when we add medication, psychiatric medication for anxiety, or psychiatric medications, chlorpromazine, haloperidol, risperidone, are antipsychotics used in psychiatry, it seems to drastically reduce the subjective experience of psilocybin. So if you pre-treat someone with these antipsychotics, it will prevent the typical response you'd see from psilocybin, ranging anywhere from 40%, to 95%. And then interestingly, haloperidol actually worsened the dread of ego dissolution or worsened psychotic symptoms in someone who is taking psilocybin. So not a good idea to use haloperidol to stop a bad trip. MAOI PK drug interactions are also critical. So if you have a drug that's an MAOI, that can prevent the breakdown of psilocybin. And we don't know much about UGT 1A9 and 1A10. We don't have any studies, but there are certain drugs that could hypothetically prevent the breakdown of psilocybin. In ayahuasca, there's very little drug interaction literature, but the big fear is adding monoamine oxidase inhibitors to other drugs that have serotonin and norepinephrine response. This slide is MDMA drug-drug interaction studies. So these are, again, more psychiatric medications. So you might recognize methylphenidate, that's Ritalin for ADHD, and that's considered a dopamine and norepinephrine reuptake inhibitor. So this seemed to increase heart rate more than MDMA by itself. So when you combine MDMA with methylphenidate or Ritalin, it can actually worsen the side effects from MDMA. So that's something we definitely want to avoid. Bupropion and duloxetine and paroxetine are all inhibitors of the CYP2D6 enzyme, and we do see some increase in the concentration and exposure of MDMA with those particular medications. But most interestingly, the SNRI and SSRIs actually see lower blood pressure. So MDMA doesn't seem to cause the same amount of increase in blood pressure and heart rate that we would see by MDMA alone when you pre-treat with SSRIs or SNRI antidepressants. So that's something that's really interesting, because in theory, you'd think by combining them, you might worsen the side effects, but the clinical studies done to date actually show an attenuation or reduction in that hypertension and tachycardia response from MDMA. The bigger problem with combining MDMA and antidepressants is that you're probably not going to notice any subjective effects from the MDMA, because these medications can outcompete at the transporter, the serotonin reuptake transporter, and that can lead to a significant reduction in the subjective effects of MDMA. Bupropion was maybe even one of the more interesting cases, because it doesn't have any serotonin effect, but it does have dopamine and norepinephrine reuptake. And that had some increase in people's MDMA subjective effects. So that one stands out as the most odd finding, I would say, from all these drug interaction studies. But at the end of the day, to summarize all of this, when you take an antidepressant like these SNRIs or SSRIs, you're going to see a dramatic reduction in subjective effects from the MDMA, and you also see a reduction in the heart or cardiovascular side effects from MDMA. This study by Dr. Fiducia and Dr. Holland and Jerome's at MAPS was very interesting. This is some of our first data looking at analysis by tapering. So they looked at people who had recently tapered their SSRI or SNRI antidepressants, or just antidepressants in general, for the half-lives prior to MDMA administration, versus the group that did not taper off their antidepressant, and which meant they were not on an antidepressant in any recent time. They didn't have to stop because they weren't taking it when they first started talking about coming into the trial. And so they found that the group that had not taken any antidepressants recently at all had bigger reductions in their PTSD symptoms, which were measured by the CAPS-4 in the phase 2 trial. So, and more of those people also went on to a remission of their PTSD as well. So this is something that's going to be very important to understand. How long do we need to stop antidepressants before people get MDMA-assisted therapy? But certainly, I don't expect there to ever be a combination of MDMA with antidepressants based on this evidence. And it's more undetermined on the tryptamine side. So the psilocybin, we're still not sure, even though there's some possible reduction in effects, there's discrepant evidence. So Dr. Bonson, who's now at the FDA, did some research in the past looking at a series of cases. People who took tricyclic antidepressants had a bigger response to LSD, and people who took SSRI antidepressants had a lower response to to LSD. So there's a lot to be determined in figuring out what potentially that interaction is going to be. And with that, I'll end my presentation and have about 12 or 13 minutes for some questions. These are some of the conferences where I've gotten to know Elizabeth and Ingmar over the years. And they have great free online webinars as well. But a lot of the people that I cited and talked about in the talk have their own talks on these from these conferences.
Great, thank you so much, Kelan. I've been monitoring the chat, and it has been quite active. So we've had a lot of discussion, and some of our questions answered along the way. So I would like to, I really thank you for that, and I second the encouragement to check out conferences and conference videos. They're a great way to learn. I want to just ask a couple of questions that came up in the chat, and in a few cases, you might hear me sort of asking your question or combining it with another one. We had a few that were overlapping or similar. So folks were really interested in a lot of the details of what you were explaining, but one thing that I think is a good combination question is to ask something about the difference between the way a lot of us are used to psychiatric medications being taken on a daily dosing schedule, and the way that psychedelics, especially in research, therapy research, are taken in a once or just a few times more intensive full dose schedule. Could you say anything about that in terms of the differences pharmacologically and the differences in terms of the effects on the body of having small daily doses of something, of a psychotropic med versus a large sort of full dose of a psychedelic?
Yeah, absolutely. So yeah, the treatment paradigm of only a few psychedelic sessions is a much safer approach than taking any medication long term, because any medication that you take daily is fundamentally altering the homeostasis of your body's entire physiology. And so by taking something and then not taking it, that is just inherently a much safer situation than taking a medication repeatedly. And in terms of the effects, I actually did work up a bonus slide in case this type of a question came up, which there's a great explanation that Carhart-Harris put out about kind of explaining the differences. So the theory as to why SSRI and SNRI antidepressants are causing their benefits is this overall downregulation in the presynaptic 1A receptor. And then what happens over time, this 4 to 6 week lag time, is a subsequent increase in the signaling through that neuron. So more postsynaptic release over time. And that's why there's that lag of your body has to sort of have this serotonin 1A receptor regulation change in the 4 to 6 weeks until you notice benefits. While the benefits of using a psychedelic are a very rapid change in the way that the brain is signaling, and then also rapid changes in all these downstream secondary messenger systems. And that's why we can see relief of symptoms even within the first day or so, which never happens with any of our traditional antidepressants. It takes 4 to 6 weeks to start to see some benefits from them.
Okay, thank you. I love that there's a bonus slide as well, and this is it. This is great. Yeah, I think that's a little understood phenomenon. And then this question came from the Q&A box, and I think it makes a good follow-up, but wanted to, someone has asked if there have been any follow-up fMRI studies looking at longer-term sustained changes to networks following psychedelic administration. So we know that it's been maybe a big dose experience and the drug is no longer present like it would be if you were taking an SSRI, but are there studies that look at those changes long-term?
That's an excellent question. That's actually a research question that I'm very interested in trying to answer potentially with the UC Berkeley institutes and things. So yes, the Fred Barrett at Johns Hopkins has started to look at, weeks later and a month later And Taylor Lyons and has looked at some of that functional imaging data at Imperial College of London. So yeah, look up some of the psilocybin to look at that temporal response. It's really interesting. There seems to be maybe some, dramatic change, and then a and then finding some new equilibrium, almost like a sine wave possible approach. But we have very little data so far, but that'll be something really important to look at, is like, how's that changing over a temporal relationship, like weeks later, months later, years later. So that data is still being actively collected by labs.
Mm-hmm. Yeah, it's just it's amazing just how much we don't know. And I always like to say, the research that most of us are doing is so focused on finding an effect and demonstrating that something can be positive for a specific diagnosis, but that doesn't necessarily tell us how that works. So lots of room for folks to get involved and start their own research projects here. Let's see, one more. Someone else has asked, this goes back to some of the earlier things you discussed, but could you say anything about the breakdown between orally consumed versus smoked DMT, especially in the presence of an MAOI?
Yeah, so if you combined, so yeah, smoke, that's a point where some people, there's been some history of looking at the smoked form of DMT by itself, which has a very short duration because the monoamine enzymes are breaking it down so quickly. But people have tried things like Pharmahuasca, where they add in an MAOI to another psychedelic compound, but I haven't seen any specific data evaluating like smoking with an MAO inhibitor on board and seeing how that affects it. But I would imagine that it would shift where it might last longer, like maybe more like an hour or two in smoked form versus the oral. Because the oral part is also having this change in terms of that it's an absorption over time too. So it's, there's less coming in and being available for MAO breakdown, whereas when you smoke, you're getting a lot of it into the circulation very quickly. And so that allows more monoamine oxidase to break it down. But yeah, the question of, for sure, I would imagine, I bet if you look on Aeroid, you might be able to find some trip reports of the combination of an MAOI with smoked DNT, but I haven't seen any clinical studies on that.
Mm-hmm. Okay. Very interesting. Let's see. We've got quite a few questions here. It's really amazing to see what the actual how much enthusiasm there has been here. I'm wondering if you could say anything. I know you have some research coming out about this soon, but anything about psychedelics that you're particularly concerned about in terms of negative outcomes or side effects or adverse events, if there's something from a harm reduction perspective that therapists or people working in this field might really want to be aware of that's on your mind right now.
Yeah, I mean, I think to me, the most dangerous thing is the MAOIs and ayahuasca in combination with other serotonergic or noradrenergic medications. And even you do have to consume a lot of tyramine in the diet, things like fermented foods, wines, things like that. So part of the dieta with ayahuasca is preventing some of those types of drug interactions from tyramine containing foods or fermented pickled foods that have higher levels of tyramine that can lead to a hypertensive crisis. And so that's what I worry about, are some of these newer novel psychedelic compounds in combination. Like, we don't really know the functional selectivity, but there's been some bad outcomes with things like NBOME series of compounds, or some of these novel psychoactive drugs seem to have more cardiovascular risk. They may be triggering the receptor in ways that we haven't characterized yet. But the traditional psilocybin tends to be one of the safest. It has a huge therapeutic index in terms of that. and MDMA has a more narrow index, but still well known in that, like I said, 75 to 125 milligram range. And then in terms of the drug interactions with the psilocybin, we just don't know if that's going to prevent its antidepressant or anti-addiction benefits. If someone's taking it with an SSRI, it's uncertain, but based on the literature, I'm not that concerned about the risk of things like serotonin syndrome with psilocybin and an antidepressant, for example.
Okay, excellent. Excellent. Kelan, I really want to thank you for all of the generous amount of information that you've shared. There are probably, if I haven't gotten to your question, please forgive me, but there are probably about 50 to 60 questions pending, and we're just not going to get through everything this evening. But I do encourage everybody to keep learning, keep coming back, and keep listening, checking out some of those conference talks. I'd like to tell you about a couple of other opportunities to continue studies, especially this topic. This video will be available to you on the online classroom through which you signed up, so you will have access to it. And we can make enduring access or on-demand access available to new people who want to register for it. So if your friends want to register, it'll be an option to do so on our website. I also want to share with you right now that starting March 8th, Kelan will actually be teaching a 12-week class, which will give you a much more in-depth contact with this topic area. It's going to go much more in depth in terms of the research and the literature. So if this kind of thing is like completely what you want to learn more about because it feels like a really good fit for you and an area of interest, please check that out. That's a small group class and it's by application only. So it'll be 12 sessions, 90 minutes, small group, lots of discussion, lots of sort of learning together experiences. We also have a whole host of other classes. We have classes on psychedelics and social justice. We have classes on psychedelics and psychoanalysis coming up in about 9 days, actually. We have a weekend workshop called Understanding Ketamine. It's a CME program, so you can get your continuing education, continuing medical education there. And we're doing our best to expand and keep the great programming coming. So I really want to thank everybody for joining us here tonight. You guys all made it such a great evening. You were coming up with questions faster than I could even read them. So fantastic curiosity. Keep the curiosity going. And I'm going to say goodnight, and we hope you come back and we see you again for more. All right. Thank you, Kelan. Thanks, Ingmar, and see you guys later. All right.
Thank you, everyone, for coming. Appreciate it.
Thank you.